Well, hello, everyone, and welcome. It is my great honor to introduce this year's recipient of the Global Interventional Radiologist of the Year Award, presented by the Global PAD Association. This prestigious accolade recognizes exceptional contributions to the field of interventional radiology and peripheral artery disease management. Our winner, Dr. Andrew Holden from New Zealand, exemplifies the pinnacle of excellence in interventional radiology. As the Director of Interventional Services at Auckland City Hospital and Associate Professor of Radiology at Auckland University School of Medicine, Dr. Holden has consistently pushed the boundaries of our field. His work has significantly advanced patient care and pushed the boundaries of minimally invasive vascular interventions in particular. Dr. Holden has been instrumental in integrating new technologies into clinical practice, including the use of drug-eluting balloons, self-expanding covered stents for long superficial femoral lesions, and atherectomy devices for long calcified occlusions in challenging anatomical locations. Now, in the realm of below the knee interventions, really tough area for many doctors, Dr. Holden has also been at the forefront of evaluating novel endovascular devices for PAD treatment. He has also advocated for tailored approaches utilizing angioplasty with drug-eluting balloons for restenosis and bioreabsorbable vascular scaffolds for proximal tibial arteries. Now, notably, he played a pivotal role in the Deeper OUS trial, investigating the temporary spur stent system for infrapopliteal arterial disease. As the first to enroll a patient in this multi-center study in June of 2019, Dr. Holden's initial experiences with the device have shown very promising results. But Dr. Holden's impact extends far beyond his clinical practice. He has authored more than 100 peer-reviewed articles, contributed to numerous book chapters, and has been a sought-after faculty member at international conferences. I could go on and on and on about Dr. Holden, but overall, his work has just paved the way for more effective, less invasive treatments, offering hope, so much hope, and improved quality of life for patients suffering from this very challenging and debilitating condition. And that's why Dr. Holden has earned the Global Interventional Radiologist of the Year 2024. So I want to welcome him now and find out what truly has sparked his passion for PAD. Dr. Holden, congratulations and well deserved.
Well, thanks so much, Kim. I'm embarrassed and honored by that lovely presentation, and I'm really honored to accept this award and feel very humbled to do so. It's been a passion of mine, really from a patient basis. With the development of minimally invasive technologies, we've got better and better at making such a huge difference to patients' quality of life, but also preserving limbs. And, really from early experience and seeing what a difference this made for patients, I became hooked on the idea of really trying to improve the field over the last couple of decades.
So, how did you first develop this, what I call a foot fetish?
Yeah.
How did you first become interested in peripheral artery disease or PAD? Or should I say leg fetish?
Yeah, leg fetish. Well, yeah, actually, one of the first case actually wasn't a critical limb case. It was a claudicant, and I was a fellow. I had a very challenging case to do in this chap who had recently retired, but couldn't really get any kind of quality of life because he had severe rest pain. He had an extensive iliac artery occlusion. And at that stage, the revascularization was not a common technique, and he was told he wasn't severe enough to have surgery. And I took on an attempt to revascularize a pretty extensive aortoiliac occlusion. Was lucky enough to be successful with that. And I got a lot of positive feedback from the other clinicians who were looking after the patient, but more importantly, received, when I saw him in clinic, he basically burst into tears saying it was the single thing that has changed the quality of his life. And he kept in touch with me regularly over the next few years. And really that emphasized the impact of what we do with a carefully planned and technically successful procedure at a patient level And that struck me and drove me really from there on.
It's so interesting that you say that this patient's doctor had told him that his disease wasn't severe enough to treat. I understand it and am full agreement with most intermittent claudicants not treating him. But we have so many that have this lifestyle limiting claudication that is truly, truly debilitating to the point where they want to go on disability because they cannot do their jobs. They can barely even function. And we have one doctor here in the US that I've had 3 patients now in just the past 6 months that have come to me. And she constantly says to these patients, you aren't sick enough for me or my team to treat. And here these patients are calling our Lifesaver hotline in the middle of the night with this debilitating pain. They can't sleep. They are hanging their legs off the side of the bed. By that point, that is CLI. And these patients may not have a wound that's not healing at that point, but they're still in CLI and they deserve the respect and some doctor to listen to them. And it sounds like you are actually the type of doctor that is truly listening to your patients and really honoring them.
Well, Kim, it's really that particular topic is something I'm quite passionate about. We have long waiting lists for patients receiving hip replacement surgery, for example, because they have hip pain that limits their walking. And yet we put up barriers for claudication, short distance claudication and rest pain. And yet, and say, look, go and exercise because exercise programs are effective. But honestly, a lot of patients just can't get started because they're so disabled. And successful revascularization, importantly combined with the other holistic care procedures, best medical therapy, exercise, can really turn their lives around. So I fully agree with you, Kim, on that one.
So, what aspects of treating PAD patients do you truly find the most rewarding?
Well, I think there's no doubt that limb salvage is the most rewarding that we see. So, we've constantly seen patients with mixed diagnoses. They're often told they've got, predominantly venous causes for their ulceration. They're often diagnosed quite late with an arterial problem. And that really, when you successfully revascularize them on the arterial side, you suddenly see this dramatic change in their clinical path. And that really is the thing I think that is most important for me. And increasingly, we used to think there are a lot of patients who we just couldn't revascularize, basically because of their distal anatomy. And now with new technologies, we're really offering a lot of these patients a limb salvage option that we couldn't even 5 years ago have considered. So that is really rewarding.
You perform a lot of research. What was that first gap in PAD care that you can recall that truly sparked your interest and passion for research in particular and helping to create the change that we all want to see and truly, creating powerful evidence-based medicine that will define the future care for PAD and its most advanced stage CLI?
Yeah, one of the things I struggled with early on was we were pretty good at crossing arterial disease and treating them with balloon angioplasty, but we weren't able to get durable results. And, when I started in the game, there were some stents available, but really they weren't durable in terms of maintaining patency. And so the drug-eluting technologies, both drug-coated balloons and drug-eluting stents that I've been involved in, really in the first in humans experience on to now widespread clinical practice, I think has made, a dramatic impact in providing durable results. And we used to think maybe you don't need to have as durable a revascularization in critical limb ischemia, but particularly with patients with significant wounds, we need longer term patency to maintain their quality of life and wound healing. So I think the drug-eluting technologies has been very impactful in my practice.
Oh, yeah, I think in a lot of practices across the globe. Now, your work on the disruptor pad plus, is that how I pronounce it? Trial explored
Yeah,
innovative approaches. Yes.
yeah, just the PAD trials, yes.
Yeah. What aspects of that study in particular, really stand out to you in influencing PAD care?
Yeah, so there were 3 trials, and the first one, well, the first 2 were really combined, Disrupt PAD 1 and 2. These were the first trials ever done with shockwave with the commercial device. I can talk a little bit more about my very first in human experience with Shockwave, but this was because I did the very first cases, but this was the clinical trial that looked to validate, did this thing even work? And so patients were randomized to either they weren't randomized in these trials. We just built up some experience with Shockwave. And wow, we found it had an incredible effect in femoropopliteal calcified disease.
Yeah.
Shockwave 1 and 2 really didn't show the durability that we wanted to see. So the Shockwave Disrupt PAD3 trial, that was the pivotal trial where patients were randomized to either plain balloon or Shockwave and then got a drug-coated balloon. And that had a highly positive result, which really meant that Shockwave became available to clinicians all around the world, including particularly in the US, who have been strong users of this technology. So that was a very impressive series of trials to be involved in.
I think that Shockwave has really been incredible in this world where there's so much points of contention with the atherectomy devices for vessel preparation, that there is this alternative. And even those who have been against atherectomy here in the US especially, they're still adopting this lithotripsy. And if you can explain, just for patients who are watching in right now, the Shockwave technology and how it works and why it is impactful, especially when paired, and it's supposed to be paired, right, with drug-eluting balloons.
Yeah, great point on that, Kim. Yeah, absolutely, because it does produce restenosis, so that you need to have an anti-restenotic therapy. But to answer your question, it's basically an angioplasty-based treatment, so something we're very comfortable with. But inside the angioplasty balloon are multiple lithotripsy sources. Now, these lithotripsy sources are high-energy ultrasound. What they basically do is they produce make gas bubbles expand and collapse within the angioplasty balloon. And that phenomenon produces sonic pressure waves or ultrasound pressure waves that transmit through the vessel wall. Turns out they're very hard on calcium, but they don't disturb normal tissues. And what they then produce is microfragmentation of the very calcified artery and return it to a much more normal state, so that you can then dilate it as you would a normal artery at low pressures, and you don't have all the complications of dealing with calcium. That was the theory, of course, but and I was very lucky to get involved right at the start as we proved its effectiveness. So, it really, as you say, I don't think it's a competitive technology for atherectomy. I think there are cases where we sometimes use both technologies, but it certainly adds to the armamentarium, and it seems to be very safe. So those issues we're worried about with atherectomy, distal embolization in particular, Shockwave just hasn't reported that kind of experience, and we certainly haven't seen that.
And it's now used in the heart, so I can only imagine that it's the FDA considers it a safe and effective device.
Yeah, very safe technology. Yeah.
So I want to talk about another technology. You're just at the forefront, and this is why it's incredibly to be talking to you right now. And I think that this is really of interest to patients and can give them so much hope for the future. And hearing some of the new technologies and what you're working on, I want to talk about your experience as the first to enroll a patient in the Deeper OUS trial for the temporary Spurs stent system in June of 2019. I want to talk about the technology as well as the unique challenges that you faced potentially in this trial and the initial results to where we are now.
Yeah, Kim, the Spurs stent is part of a larger group of technologies called vessel preparation devices that we're going to hear more. And Shockwave actually is one of those as well. But what we mean by vessel preparation devices is saying, how can we prepare the vessel so that it responds much more effectively and durably to balloon angioplasty, the established treatment for occlusive disease in lower limb arteries. And so the Spurs stent is a technology designed to do that. It's an incredible technology that Reflow Medical have developed, with a temporary stent with spikes or spurs that are deployed into the vessel wall. And the theory at the start, at least, was that would mean that the vessel compliance or its ability to stretch up was different, but also that these little spikes in the vessel wall would allow drug to enter into the deeper layers of the vessel wall where it needs to be to have its anti-restenotic effect or prevent restenosis. So we enrolled the first patient, and we're one of the enrollers in the DPRO-US trial. This was a trial, the first trial using this technology in below-knee arterial occlusive disease. You mentioned the challenge. One of the challenges is showing a video of the device itself. When you look at it, it looks like, wow, that's pretty aggressive to be deploying this thing with spikes and going into my artery. And
Yes.
people were a little bit concerned about, would I be feeling this? Would it be painful? Would it cause major trauma? And so you needed to get patients trust and reassurance. And of course, that is this is a non-traumatic technology, and we saw a really good safety profile with our first human experience. So our experience really was that we were producing a different kind of angioplasty. It did look like there was a permanent stent in the arteries, even though you pulled the stent out at the end. And on follow-up in our cohort in the DPRO-US trial, the restenosis rates looked significantly lower than what we'd normally expect with plain balloon angioplasty. So the company sort of hasn't sat on their laurels with that. They've done another trial using a different type of drug, paclitaxel, a limus rather than paclitaxel. And they're studying, as you know, Kim, quite extensively in the US, and there are new trials being planned in the near future as well.
And they've already gotten CE mark. We're still working on it. I hear here in the US, and looking at possibly 2025 before we actually hear maybe the first quarter. But something else that's interesting, and I love that this is all happening in New Zealand, but I heard that it's also being tested for the heart and in-stent restenosis in New Zealand as well by one of your colleagues.
Yeah, well, and here in Auckland Hospital, that's right. So yeah, it was, and we had we've been very, very privileged to do that. We actually did the same with Shockwave as well, and it's kind of because we've got a good setup here with research support, so we can do high quality care, and so it's great to have those opportunities.
So, as this prolific researcher across various vascular territories, how do you prioritize your research focus between critical limb ischemia, intermittent claudication, lifestyle limiting claudication? Where do you think the greatest gaps are even still today?
Oh, look, I think the greatest gaps are in critical limb ischemia because we have a global pandemic of that technology, and we have a whole group of patients that we still don't do particularly well in. The chronic renal failure patients with severe calcium distal calcification, the patients without a distal target. So I think those are the ones we still need to keep on, and also scaffolds. That we do know that below the knee we need durable scaffolds. So those are kind of some areas, but prioritization for us really, when we started off, we were very interested in trying to build up our team. So we maybe would take on a variety of trials. And as we've been lucky enough to, I guess, gain experience and reputation, we tend to cherry pick trials that we think will make a difference. They're pivotal trials where the technologies are going to be, for want of a better term, disruptive. And so that's what we tend to focus on. And we're very lucky to be in that position.
Well, I think so far that you've picked them right, because you really are on the cutting edge of what we even consider the Global PAD Association, literally the defining technologies for the future of PAD care and limb salvage. So congratulations to your team on that for picking the winners, or what we hope will be the winners. Now, I have a final three set of questions that we ask every single doctor, every award winner. So here we go. They take a little bit extra thinking. We're hoping that you can come up with very specific cases and examples versus just generalities, specific examples that would represent a grander trend. But we'll see what you do with them. The first one is for our Journey to Diagnosis series. And we want you to share a case that had you scratching your head about how in the world this patient was not diagnosed sooner, and what you wished would have happened differently with that patient. Do you have a story to share about a patient who should have been diagnosed with PADs sooner?
Yeah, I do actually, and it was it was actually a woman who was a good friend of my mother's. So I should have been involved a little bit more often than that. But she had a severe lower limb ulcer. She was a little overweight. She had some venous incompetence, and she was really struggling to get traction with clinicians to try. She had a whole lot of supportive care. She had some superficial venous treatment, and she was someone who didn't like to complain. She was someone who didn't want to make a fuss. And it was really and we often see these patients who are not in the position to really forcefully drive for better care. That was my mother contacted me and said, "Look, would you mind having a chat to her?" And it was very quick and easy. I popped in and saw her. It was very clear on a very brief examination that she lacked distal pulses. She ended up having very straightforward reconstructible tibial trifurcation disease. And so really it was the in the community, the fact that the general practitioner, the fact that the venous specialists had not clicked onto arterial insufficiency, and we see that time and time again. So a simple case, but really a case that we would see in our practice many times with a delayed treatment. Of course, once we did revascularize, within the space of 6 weeks, she was healed and her quality of life was durably improved, in the long term.
If only the doctor would have touched the patient,
Yeah,
felt those
exactly.
pulses.
Yeah,
Life and limb, right? Can be saved a lot
exactly.
more.
Yeah.
Okay, share 6 minutes that matter in your career. It has to be a defining moment. Catalyst for change, a spark that led you in a specific direction. It could be a conversation you had with someone, it could be a scene in a show or movie or documentary, but we want a moment that it truly was defining for you in your career.
Yeah, I mean, I think it's probably a person. I was obviously really interested in intervention, endovascular treatment, and someone who's they'll be embarrassed by me saying this, but someone who really has changed the way I started to think was a vascular interventionalist in Leipzig in Germany, Andre Schmidt, who I'm sure many of you know. But I was lucky enough early on to go one of the early Link meetings and get to know Andre and get to see him. And as a practitioner, he opened up some of the possibilities that I hadn't considered. Obviously, this was early on with retrograde approaches to patients who were told, we can't cross your lesions, there's nothing more you can do, and a number of other technologies. So that first day that I saw him doing live cases and did a retrograde pedal approach, I took that experience back to Auckland, did the first retrogrades that had been done in our country, and then it opened up to thinking, okay, I'm not going to accept that there's nothing that can be done. This is more a creative artistic process rather than only pure science. And I need to be creative on how I can reconstruct patients' vasculature. And that approach really affected me. So I'd like to think now that, our group, we're thinking, hey, is there anything else we can think of here? And now we think of, yes, retrograde approaches, distal approaches. Can we do deep venous arterialization? Is there some other technologies that we can think of to offer these patients a solution? So that was very impactful for me.
And I love that you don't have this why delay the inevitable type of mentality, because we still get that literally across the globe. It's, well, they're going to lose it anyway, but every patient will tell you, I would rather walk to live another day and live to walk another day than to have my limb chopped off. I would rather die in dignity. And we hear this from our patients all the time. And so that's why we love that there are doctors like you out there that we can celebrate and spread awareness of, who are really trying to exhaust all efforts to save their limbs and their life. And, if they're going to literally, they're going to be on deck anyway in many people's eyes, then why not at least try, right? At least these patients won't have any sort of regrets. So that's really important. Before we do our last final question, which is one that we ask everyone, I just want to piggyback onto what you had just said about the retrograde approach and taking that distal approach. We've never had anyone actually explain to our patients why retrograde actually matters before amputation, because that's something that we always tell our patients. Make sure when you're choosing a doctor that they have the ability, when medically appropriate, to perform both an antegrade approach coming down from the groin, as well as a retrograde approach, either coming up with pedal access or tibial access, and coming up from below. Why is it that it may be easier at times to come up and tackle a blockage from below?
Yeah, great question, Kim. Blockages in the arteries, we define them as having caps, both a proximal cap, that's the cap at the top of the blockage, and a distal cap, that's the cap at the distal end. And putting guide wires through these caps, that's where we can get into trouble. That's where the guide wires may end up going somewhere we don't want them to. We call that dissection, and that will fail. We then can't treat the patient. As it turns out, and we still don't know quite why this is, but in many occasions when you've got a blockage, particularly of the arteries below your knee, a guide wire is much more successfully likely to cross coming from below through what we call that distal cap than it is coming from above. We always start from above because we prefer to get access in a larger artery in the groin. That's technically more straightforward, and we can then deliver bigger devices like balloons and stents. But if we can't do that, and we do have some devices to help us, but still, it's not uncommon where we can't do that in someone with critical limb ischemia, we then need to offer the patient the second approach. Usually we set up at the same time. So we consent our patients that we're going to start this procedure antegrade or coming from above, but we will be prepared to prep and drape either the lower calf or foot in case we need to do a retrograde approach. So it's really to achieve guide wire crossing of blockages. Once we've got a guide wire across that, we can often convert that approach to the downhill approach and complete the procedure. But a procedure cannot be successful unless we've got a guide wire across it at the start. And to be honest, in critical limb ischemia, retrograde techniques, everyone offering critical limb intervention should be facile with that.
Yeah, and just so everyone understands, it's really important for that guide wire to get across, because every other device, the balloons, the stents, they use the guide wire as navigation. They all slip over the guide wire to navigate the vessels more effectively and efficiently. So that's why it's important. Okay, one more question if you have quick time. Just a case that had a big lesson for you and potentially a big lesson for others. Success or failure doesn't matter.
Yeah, I thought a little bit about this, and this is something we're about to publish, and I think it's important. This relates to variants of vascular anatomy. So we don't all follow the anatomy books and that includes our arterial anatomy below the knee. It might be interesting to know that the main artery behind the knee is the popliteal artery, and that in the embryo continues on down the calf to an artery called the perineal artery, but then it gives off two branches that become the main branches to the foot. That's the anterior tibial and the posterior tibial artery. Now, it turns out that sometimes there are variations, so that, for example, the posterior tibial artery may be absent congenitally high up in the calf, but then it's fed by this perineal artery lower down. We call this posterior tibial continuation of the perineal artery. The point being, you've got to be aware of these anatomic variants. And I had a case where clinicians had previously said this patient has a long posterior tibial artery occlusion and we can't get through it. And it's the main artery in the foot that we need to connect to. We could see it in the foot, but it looked occluded in the calf. And they had 2 or 3 attempts, both antegrade and retrograde, at getting this through, and they dissected and they weren't able to get through. And the patient was being considered for a transmetatarsal amputation. And I looked at the imaging and could see an anatomic feature at the level of the calf that I thought, you know what, I reckon this is actually the perineal artery that is supplying this. And the perineal artery had blockages as well. But we then did an approach through the perineal artery, and sure enough, we could get into the foot. And really all this patient had was an anatomic variant that wasn't recognized. And our endovascular strategy was therefore changed. I would think these important variants are seen in about 10 to 15% of the population, and we haven't done as good a job as we could do at understanding and explaining that. That's why we're about to publish this, because it does come into clinical experience that recognizing these variants can really influence our strategy. So that was a really important lesson for me, and luckily enough, it had a really good result for that patient.
So even before amputation, again, double check. I mean, could there be an anatomical variant that is that you may not recognize, that you need to take a double look and see if there is something different, and maybe something you can MacGyver and create something new. So thank you so much, Dr. Andrew Holden, our interventional radiologist of the year, our global interventional radiologist of the year, director of interventional services at Auckland City Hospital, and associate professor of radiology at Auckland University School of Medicine. Congratulations, Dr. Holden. We appreciate all you do to save life and limb and inspire others to do the same.
Hey, thanks, Kim. It's been a privilege to spend some